now our dear friend Peter Wilson, cardiologist, endocrinologist, and all epidemiologists and everything that ends with ist.
Is so I'm just going to leave this slide, the title slide up, and I'm not going to advance. And in the interest of time, because we all want to go home, and that's the question. I think is I disagree with several of the issues that were raised in the previous presentation, and I'll go after. I have about 5 points to make, and every time I get to hear a talk related to testosterone, I listen. And I think we all should listen. I think that's an important, because the previous speaker just changed exactly what he said. Everything he said about the Traverse study was true, but he didn't say everything about the Traverse study. And I'm going to say a couple of other things that I have yet to hear a urologist or many clinicians actually. And Peter Snyder, who was the author of on the Traverse trial, had also misstated some of the results of the Traverse trial 2 years ago, and I questioned him on it. And I'll get to that point in a second. So number one, I'm just going to give you some pearls from recent talks. Shez Basaria from Harvard, who's on the Traverse trial, he said, one of the biggest mistakes we're making is assuming pre-testosterone is correct. That's important. And I think we in endocrinology and in urology, we should really make sure that we're getting good accuracy. He does not think free testosterone is done very well, except you send it out to reference labs. So that means you have to use the SHBG formula, and most of us don't have time to do that. But we should probably start leaning on our local labs to do the equilibrium dialysis. That's the key word, ED. Equilibrium dialysis measurement if you're going to be treating a lot of them, and you're going to be measuring androgen levels. That's number one. Number two, prior to the Traverse trial, Matt Budoff wrote a key paper. And the key paper was what happens to coronary artery calcium and CTA angio after 1 year of androgen replacement therapy, TRT. The answer is CAC does not change. Soft plaque changes. Soft plaque changes. And Matt Budoff, to get that paper published, he had to repeat a lot of the studies that were in the TOM trial at major cost, and it's in JAMA. It's a JAMA paper type of, and soft plaque is going up when you're taking testosterone replacement therapy. That's number two. Very few people mention that. That's very important. And as was shown in the previous presentation, a lot of the data goes both ways, and it's hard to interpret what goes on. I think things may be very different for like the young people who don't have severe atherosclerosis versus the typical person. I'm in a VA clinic. My typical patient's 60s and 70s, which leads into who was in Traverse trial. It was exactly as mandated by FDA. They should be treated according to ACC, American College of Cardiology, and the American Heart Association guidelines, which means people at high risk, people who already had heart disease, and people who were at high risk who had not had heart disease would get treated to lower their risk, which meant statin use. And nobody mentions, 80% of both arms were on statins during the entire trial. And I want to say that's something that every urologist ought to be saying to each other, is you have somebody probably 50 plus, and you know, if you think he's at risk, you can do a risk calculator, but you can also, I tell my patients, you know, I think this is a tiebreaker now. I'm putting you on testosterone because if you have primary disease in your gonads or you have pituitary disease, because I see both, and I'm going to put you on statins. It tie breaks for me. And for the patients already on statins, I pay attention to their LDL. So that's an easy one, you know. The other one, the last one, this is my last 2 points. That wasn't mentioned in the previous trial. testosterone is not an accepted treatment for osteoporosis. We do not accept that. All the bone experts do not accept that. And what was the second paper in the Traverse trial? That was Peter Snyder. It led the trial, that aspect. Increased fractures. Yes, increased fractures on the T patients, those who got testosterone replacement. So we probably need another trial to sort that one out. And it's probably going to be older patients. It's not going to be the 20 to 50-year-olds who are hypogonadal at the primary gonadal level. That needs to be sorted out. And then finally, depression. So I see a lot of patients with low testosterone. We repeat it. We have the usual, slightly different endocrine and guidelines are very strict to treat. And we have to measure it twice, 8 a.m., et cetera. But in the VA, I have 30% of veterans are depressed or I have a mental health diagnosis, which leads to a lot of mental health medications. And they're not necessarily, it's just the depression. They're on the medications that can affect the testosterone. And that's probably an indirect effect. And so urologists are not going to do this, but just be sensitive to the idea that these people, some of these patients, and I have a large number of them, they have elevated prolactin. So the medication is elevating the prolactin, and I get them off the prolactin and off the medication. I switch them to others, and their testosterone comes into the normal range, and that's something that you could potentially do as a urologist. You see the low T and the person's already on a psychiatric med, and we'll get Dave's reaction to that, is at least get a prolactin and or potentially have the psychiatrist consider, can they switch a medicine? And the list of medicines that raise prolactin, and the prolactin is not super high, the list is over 100 medications. It's really long, so I'll stop there.
Yes. I don't know if this is on.
Well, just stand up there, Dave.
Yeah.
Step forward.
Here we go. It's on.
So what I think we just heard from Peter is really critical to what it is that we do. And that's, I remember when the WHI, the Women's Health Initiative, came out, I was at the NIH, and a number of the conclusions that they came up with, it's not that they did the wrong statistics, but they didn't take into account. The majority of the women in the trial had at least 1 to 2 packs of smoking cigarettes a day, that there had been obese, that there are many other factors. And I really like the idea, and again, applaud him directly, is that the role of psychiatric drugs, they're not just, mood enhancers. They affect a whole number of systems within that. They don't just block the reuptake of a monoamine neurotransmitter or the postsynaptic attachment of a monoamine neurotransmitter. Certainly the antipsychotic drugs have been very well demonstrated. Metabolic syndrome, prolactin issues, and we know this, but if someone was acting crazy, they use them, and they're effective drugs. But I think the issue of trying to not simplify something and if we understand the mechanism, sometimes not only does it lead us to the next good question, but a more thoughtful decision on how we move forward. One of the things I hate, why I love lifestyle psychiatry, is the 6 pillars have nothing to do with medications. They don't say you shouldn't use them. We don't say they don't have an important role, but assess each of those 6 pillars as a clinician, as a healthcare provider, and what can we do? And interestingly, the majority of them have a very biological effect. So exercise with, how much is good? Diet, does everyone have to go on, a strict vegan diet? Of course not. But I think understanding that each of these can account for some of the variance. And we need to be looking at, is it as simple as this equals this? And in medicine, I find it almost never is. So the first thing I look for when someone comes in, what I look for in depression, was it a recent onset? I've been happy most of my life. Depression doesn't run in my family. And over the last week or two, I've just, and they start listing the symptoms of depression. Well, they meet the criteria. But what happened in the last 2 weeks? And if there's nothing that happened, then I got to start thinking, well, maybe what's happening physiologically, biologically, medically? Am I worried about something? Or am I taking a medication? Maybe I changed the dose. That's affecting other neurohormones. So there's no question the neurohormonal system plays an important, critical role in how we think, how we feel, and how we behave. There's data now looking at even with substance abuse. So I think I couldn't agree more with Peter that not that we say it should be used all the time. We say this is something we should consider. We should put this into our equation, get as many of the variables attended to as we can, and then we make a differential diagnosis and come up with a treatment strategy, but then monitor it. That's why I asked the question earlier. I'm concerned when we take this and come back and see me in 3 months. And I'm not talking about psychiatry. I'm talking about other medical. A lot can happen in 3 months. So I think if we have the capacity to monitor things without kind of pushing the workforce to the point of the brink, that through chatbots and some other things that are available now, that might help us advance our field to get better monitoring of patients so that we can tweak and modify and personalize our treatment strategy. So I think this whole precision personalization is to all of medicine, and I couldn't agree more. Let's try to understand all the variables that might be contributing to this clinical phenotype that we're trying to address.
Thank you so much, guys. It's been a wonderful, wonderful session. Thank you so much for being here. You know, it's heartbreaking that someone could miss this section because it's kind of at the heart of men's health. Everything arises from this, and you are the best. So thank you so much. Thank you, Catherine. Thank you, everybody. I love you. See you tomorrow at 7:30. Tonight is free. You know, we have just professor's dinner, but the day after tomorrow, we do have some pachanga and, you know, dancing and eating and get us drunk. Yeah? I don't drink. Bye.